Subscribe now and press the bell icon. Never miss an update.
Good morning, buenos días, namaste. Well, let me, Shushma opened the path, we're dealing with the same problem. This presentation is about DIANOVA presents how do we the process of mainstreaming a gender perspective in a TC or in a treatment center. I'm Elena Goti, I'm DIANOVA's vice president and a very old-time friend of WFTC. I think my first conference was in 1990, so I'm a long-time friend of WFTC. Let me tell you, I'm very pleased to be in Delhi. Now a few words about DIANOVA, very short, just to let you know that it's a network of foundations and non-profit associations working in the social and health fields. We are present in 19 countries in 4 continents. 2 of our partners are from India, and we are strongly committed to social process. We began our work 35 years ago as a self-help community offering services for drug abuse at the grassroots level. So we worked at the grassroots level. We were not a TC yet. We were just a community for drug abusers. There was no reintegration process. They were just living there and being away from drugs. But DIANOVA evolved, and in 1990 was founded by grouping a really full-fledged TCs. From 1990 on, it became really a full-fledged TC group of communities. But the last 10 years, to grassroots treatment programs, we added to our agenda advocacy in national and international forums in the field of drug policies, health, human rights, and sustainable development. At the policy level, DIANOVA has conducted gender awareness-raising campaigns focused primarily on the need to consider women's specific needs in policymaking. The 3 campaigns are Quit Stigma Now, the second one is Empowering Women, Empower Society, and the third one is Human Empowerment. At the advocacy level, DIANOVA is a great advocate of the gender perspective in addiction treatments, specific. Gender perspective in addiction treatments. We have organized event along with partners, some are here now, at CND, at the UN Human Rights Council in Geneva, the Commission on the Status of Women in New York, and the European Union Social Society Forum on Drugs. Well, this is about DIANOVA. The question is, let's move on to why do we need to have a gender perspective in TCs, in our centers? Why do we need it? Why do we need that? First, because men and women follow different drug use patterns. As the World Drugs reports in 2022, men who use drugs are more likely to externalize behavioral problems, to suffer attention deficit hyperactivity and antisocial personality disorders, while women who use drugs are more likely to suffer from internalizing the problems, from depression and from anxiety. Their drug use progression differs too. Men have higher prevalence of drug abuse, while women tend to a faster increase in consumption and progression rate. If we focus on consumption's social consequences, we find women bear a double stigma. One for using drugs, the second for not meeting roles expectations, and consequently they receive less family and social support. Plus, when they come to treatment, they generally are trauma and violence survivors, or they were sex workers and suffer more vulnerabilities and comorbidity. If we focus on the access to treatment, we find women are underrepresented, either because they have additional barriers, such as lack of children care support, or because they fear legal sanctions and losing their children custody. Recent data in Spain, was 2 months ago, we had that data, shows that women start treatment 9 to 11 years later than men. 9 to 11 years later. A third item that differences is about the need of a gender-sensitive approach is that women have less adherence to treatment and progress less favorably than men, since most treatment designs do not take their specific needs into account, and they are under increased pressure to leave and return to family responsibilities assigned to their roles. How do we mainstream and implement gender perspectives in a treatment center? We really recognize that there have been significant progress in recognizing the need of having gender-sensitive programs, but have they really been implemented on the ground? How do we mainstream and implement them? How do we make it happen? It is not easy. Implementation is not a single but a long-term complex process. So no single action. You don't implement it by doing one thing. It's a long-term complex process. It implies transversality, not unidirectionality. And it depends on and requires of political will, as it affects organizational structures, social context, and the economics. In addition, its enforcement must be undertaken at all levels. And when I say all levels, it's all levels of the organization, from managers, professionals, technical teams, beneficiaries, volunteers. Changes should even affect the facilities. The organization must change from the top down, and this ranges from having an equity plan to implementation reconciliation measures, ensuring that there are no power relations, reviewing language, and language is oral and written language, removing barriers to access to services, and especially, this is main, continuous staff training. The process of implementation requires to develop some specific interventions. We're designed from a male-centric perspective. Therefore, we need to develop specific gender-based interventions. Staff should be trauma-informed, which takes into consideration beneficiaries' previous traumatic experiences, not when they start doing drugs, previous, such as gender violence, child abuse, accidents, war, migrations, and include them in their work and their activities. The second change we need to introduce is specifically address gender violence, because violence and drugs form a common and complex duo, a key issue to address in therapeutic work, either as initiating or as an aggravating factor. The Pompidou Group in 2012 informs the prevalence of experienced violence is higher in women who use drugs than males who use drugs. And the World Drug Report reports women who use drugs have a prevalence of suffering gender-based violence 2 to 5 times higher than women who do not use drugs. So women-only interventions, women-only group therapy to deal with gender-based violence are recommended in a center. The third specific intervention we recommend is related to child care needs. Given that one of the main barriers for women to enter and remain in treatment is their compatibility with the care of their children, the provision of services that include comprehensive care of children would facilitate their access, their adherence, and their participation in treatments. Now, the next is one of the main issues to do in therapeutic communities and in treatment centers. All team members professionals and non-professionals must receive training in gender perspective. It is not enough to include a gender expert in the team, because everyone must be sensitive to gender. It must be mainstreamed. In our centers, we invite and encourage each member of the staff in our centers to contribute initiatives and to propose measures, since each of them must be aware of their implications. Otherwise, interventions to risk being biased or inconsistent or even counterproductive. One example, in one of our centers, we trained only one staff in gender perspective, was very well trained, not all the staff. He encountered resistance to changes, peer pressure, and it all ended up him burning out. A key point is training should not be academic, it should be experiential, self-experiential, with the aim of reviewing one's own prejudices that are still active or remaining. We're speaking about our staff. Regular team supervision sessions are very useful to this purpose. A second example. An individual's women's session focuses on empowering her. When she leaves the room, someone, a man, makes a sexist joke. Other men laugh. We ask ourselves, is there a lack of coherence? Does it mean a weak ethical code? So let's be clear and forceful. Gender must be included in all spaces, formal and informal, therapeutic or social, to help change inappropriate behaviors in everyone, everywhere, always. When training staff, we know that prejudices persist among our people, among ourselves also, among public services officers, addiction service providers. Some examples of prejudice would say, women in treatment are more complex, more difficult to manage. They are less motivated, more manipulative. A specific one, women are more prone to risky behaviors, while men are really impulsive. They're only impulsive. Women are prone to risky behavior. Those are prejudices. Staff training should promote a wider views, interventions, conversations. For example, about motherhood. Under an activated gender perspective program, it's not assumed that all women want to be mothers. So we listen, we discuss, we think about it together, and we always treat it with respect. In this way, we indirectly avoid a feeling of guilt and of being further stigmatized. Where, in what programs should we develop the gender perspective? That's the next question. The answer is simple, in all types of programs, since all program modalities must include it, whether in programs for only women, only for men, or in mixed gender fluid programs. We need to guarantee confidentiality and privacy, to create physically and emotionally safe spaces for everyone, for each one and for everyone. Facilities must be adapted and have separate bathrooms, toilets, and we need to eliminate spaces and corners where people need to get too close. Safe places. What happens with men-only programs? There we work with new masculinities. I was thinking of the children we visited about the day before. Only boys. You can still enter the gender perspective with boys. I'm sure you do it.
No, for female we have a separate, for girls we have a separate center.
Okay. But this is only men, and we still work with gender, new masculinities, as you say, yes. What do we mean when we say new masculinities? It is about identifying and deconstructing masculine mandates associated with drug use, being macho, be strong, be cold, be tough, because it leads to positive associations with stimulants, cocaine. it leads to macho sexual behaviors or the use of substances that they help to evade emotions and be a tough guy, highly valued in the masculine identity. I remember a visit I did to a retreat I passed in Amity Ranch, in Arizona, where 80% of the residents there were males and really tough guys. Believe me, they were really tough, Latino, Mexican, really hard boys. One night they woke, one morning they woke us all up in the morning. Very early, it was still dark, and we walked across the ranch to a beautiful hill there, and we all sat, we were about 100 persons there. No speaking, silence was required, so we sat there to wait for the sunrise. And we spent, and so the sun, we could see the sun coming and rising, and you can hear the birds going by. When you thought of those 100 tough guys watching at the sunrise in the morning, no speaking, listening, smelling the flowers, the morning, it was so incredible. And Naya Arbiter, who was at the moment organized those activities, she said, I want them to feel that they can also feel that it's not a problem to feel the contact with nature, the contact with themselves. To me, it was a learning opportunity. We work appealing to emotional education, not academic, not intellectual, emotional education. Our objective is to open the way beyond and outside of it. Questions we ask ourselves: do the tools, strategies we implement have positive results? What should be done? A very, very effective tool that we use and we recommend is to collect gender disaggregated data when designing and evaluating services and outcomes. Gender disaggregated data will help design, evaluate where necessary, where do we need to modify or redesign services. It's a key tool. We can know how men or women adhere to treatment, how long men and women stayed in treatment, what strategies were effective for whom. Well, I have one more I would like to share with you. This is not exactly with women, but I need to include children in this presentation. The perspective of children whose parents or caregivers use drugs. They are more likely to develop health, social, physical, and psychological problems, and should also be included as a group. We must break their barriers of invisibility, so we will refer them to specialized services. We cannot have them with us. We need to guarantee this and all children a healthy and nurturing environment. Where possible, within the family. When it's not possible, we ensure the support of the appropriate social services. As Agnes Chen from Stutling Community in Canada, one of our members, said, indeed, children do not have a choice in the kind of home environment they are raised in. But as a community, we have a choice in the kind of community environment that supports them. My conclusion is very, very simple. It's not enough to have a gender-sensitive approach on paper. It should be mainstream and implemented on the ground. And it should be constantly be adapted and broadened. Thank you very much.